Welcome to this week's Neurology Deep Dive. Just a reminder for everyone listening, this is for educational purposes, it has no commercial goals, and it's really a summary of a research paper. We strongly encourage neurologists to read the full publication for all the details.
Absolutely.
Today we're looking into the second European carotid surgery trial, ECST-2. This study asked a pretty fundamental question. Does adding carotid revascularization, that's surgery or stenting, to optimize medical therapy, actually improve outcomes for patients with carotid stenosis compared to just sticking with the best medical therapy alone?
And this is so important because, the guidelines we often rely on for carotid stenosis, they're mostly based on trials from well over 30 years ago.
Before modern medical treatments really came into their own?
Exactly. Before our current statins, antihypertensives, the works. So ECST-2 wanted to see if invasive procedures still add benefit now that our optimized medical therapy, meaning top-notch control of blood pressure, cholesterol, diabetes, plus lifestyle changes, is so much better. Specifically for patients with asymptomatic stenosis or those symptomatic but considered low to intermediate risk.
Okay, let's get into the specifics. Who exactly was enrolled in this trial? What were the inclusion criteria?
They included adults 18 or older who had carotid stenosis of 50% or more. Now, for patients who were symptomatic, they needed to have a predicted 5-year stroke risk of less than 20%,
And how was that predicted?
using the Carotid Artery Risk score, the CAR score.
Yeah.
They also included patients whose stenosis had been asymptomatic for quite a while, at least 180 days. The assumption there was that these patients likely had a low 5-year stroke risk, say 5% or less, just with medical therapy.
And key exclusions?
A main one was having had previous revascularization in the artery being studied.
Makes sense. So how did they set up the comparison, the study design?
It was a multicenter randomized trial. Patients were assigned to one of two groups, either optimized medical therapy by itself or optimized medical therapy plus revascularization. The choice between carotid endarterectomy or stenting was left to the local investigator.
And the main thing they were measuring, the primary outcome.
It was what's called a hierarchical composite outcome, looked at over 2 years. Hierarchical means the outcomes were ranked in order of severity.
What came first?
Top of the list was periprocedural death, fatal stroke, or fatal myocardial infarction. If there was no difference there between matched pairs of patients, they looked at non-fatal stroke, then non-fatal myocardial infarction. And finally, any new silent brain infarct seen on imaging, like MRI or CT.
All right, let's talk results. What did they find for this primary outcome after 2 years? How many patients were involved?
They randomized 429 patients in total. 215 got medical therapy alone, 214 got medical therapy plus the procedure. The median age was 72, and about 69%, so over 2/3 were men. And interestingly, 40% in each group were symptomatic patients.
And the main finding?
The bottom line for the primary hierarchical outcome at 2 years: no statistically significant difference between the groups. The win ratio, which summarizes the comparison across that hierarchy, was 1.01.
Very close to 1, meaning no clear winner.
Exactly. The 95% confidence interval spanned from 0.60 to 1.70, and the p-value is 0.97. So really, no evidence that adding revascularization provided an overall benefit on this primary measure within 2 years.
That's quite something. It suggests that for many patients we might have previously sent for procedure, optimal medical therapy could actually be enough.
It certainly points in that direction based on this 2-year data.
What about the individual parts of that composite outcome? Did anything stand out there?
Let's break it down. For that most severe category, periprocedural death, fatal stroke, or fatal MI, there were 4 events in the medical therapy group versus 3 in the revascularization group. 1 death in the revascularization arm, it should be noted, was related to aortic stenosis complications after a carotid endarterectomy.
And non-fatal strokes?
A bit higher numerically in the revascularization group. 16 events versus 11 in the medical therapy alone group.
And heart attacks, non-fatal MIs.
That went the other way slightly. 5 in the revascularization group versus 7 in the medical therapy alone group.
And the silent infarcts on imaging.
For the subset of patients, about 242 who had imaging at baseline in 2 years, they found 7 new silent infarcts in the revascularization group versus 12 in the medical therapy alone group. But again, none of these individual differences reached statistical significance in the main analysis.
Were there any secondary outcomes you think are particularly relevant for clinicians?
Yes, a couple. The straightforward composite of periprocedural death, any stroke, or MI was very similar, about 10.2% with medical therapy alone, 10.5% with added revascularization.
So no difference there either.
Pretty much identical. Looking just at stroke in any brain territory, it was 5.9% in the medical therapy group versus 8.6% in the revascularization group over 2 years. That difference wasn't statistically significant. The p-value was 0.14.
But what about stroke on the same side as the stenosis? Ipsilateral stroke.
That's an interesting one. Ipsilateral stroke occurred in 2.9% with medical therapy alone versus 6.2% with revascularization. The p-value there was 0.052.
So very close to statistical significance, possibly hinting at a higher procedural risk or early hazard.
It's suggestive. Certainly warrants watching in the longer-term follow-up. Myocardial infarction rates were numerically lower in the revascularization group, 2.5% versus 4.9%, but again, not significant. One other point, all-cause hospitalization, excluding the hospital stay for the initial procedure itself, was actually a bit higher in the revascularization group, about 35% versus 27%.
You mentioned how good modern medical therapy is. How well did patients in this study actually stick to it?
That's a really key point.
Yeah.
Adherence was excellent in both arms. At 2 years, you had 97 to 98% of patients on lipid-lowering drugs,
Impressive.
and 86 to 87% were taking antihypertensive medications. This high level of medical management is likely a major reason why the outcomes in the medical therapy alone group were so good.
Now, procedures always carry some risk. Were there notable complications in the revascularization group?
Yes, among the 191 patients who actually had the procedure, 8 of them, that's about 4%, had a stroke within 30 days. One of those strokes was unfortunately a fatal cerebral hemorrhage.
And other procedural issues.
Specifically for the 181 who had carotid endarterectomy, 12 patients, or about 7%, experienced cranial nerve palsy within the first month. It's also worth noting that 22 patients who were initially randomized to medical therapy alone did end up having revascularization later during the follow-up, and none of those had a stroke within 30 days of their delayed procedure.
So pulling this all together, what did these study investigators conclude from this 2-year analysis?
Their interpretation was clear. Based on this interim data, there's no evidence that adding carotid revascularization to optimized medical therapy benefits patients who have 50% or greater carotid stenosis, but are predicted to have a low to intermediate 5-year stroke risk. That's the CR score under 20% group.
Implying that medical therapy alone might be the best initial strategy for many of these patients.
Exactly. It supports considering optimized medical therapy as the primary and potentially sufficient approach for a large number of patients with asymptomatic stenosis, and also for those symptomatic patients identified as lower or intermediate risk by the CAR score. The stroke rate with just medical therapy in ECST-2 was much lower than what was seen in those older trials from decades ago.
So the take-home message for neurologists listening, based on these interim findings.
For your daily practice, this 2-year data really strengthens the case for optimized medical therapy as a powerful and perhaps primary treatment strategy for many people with carotid stenosis specifically, asymptomatic individuals or symptomatic ones deemed low to intermediate risk, using tools like the CAR score. It emphasizes really maximizing that medical management first.
As we wrap up, what are the key caveats or final thoughts neurologists should bear in mind?
Well, it's vital to remember these are the 2-year results. They're interim. The 5-year data from ECST-2 is still to come, and that will give us a much fuller picture of the longer-term effects. So clinical decisions still need to weigh these findings against individual patient factors, their preferences, and their overall risk profile.
And as always, read the full paper.
Absolutely. The complete methodology, results, limitations, it's all in the Lancet Neurology publication by Donners and colleagues. And looking ahead, future research really needs to focus on better ways to pinpoint which patients do have a higher risk despite good medical therapy, maybe using advanced plaque imaging or other biomarkers so we can personalize treatment even better.
Which leaves us with a thought-provoking question for you, our listeners in neurology practice. Given this evolving evidence showing just how effective optimized medical therapy can be for low to intermediate risk carotid stenosis, how might this shape your approach and your conversations with patients about the role of revascularization?